For the next few minutes, I'll be talking about the role of glucagon to prevent hypoglycemia during exercise. To give you a brief context setting, as all of us know, there is no known cure for type 1 diabetes. What we generally do as far as diabetes management is concerned is giving people regular insulin injections from outside and exogenous insulin injections and careful dietary management so that you tend to be in a narrow zone of euglycemia. And to ensure that you maintain euglycemia at all times, exercise is an important component of prevention of diabetes and also in the management of diabetes so that you can reduce your insulin doses with its inherent risk of hypoglycemia. And multiple studies have actually told us that all-cause mortality is approximately 50% lower in people with type 1 diabetes who generally have an exercise equivalent to 7 hours of brisk walking per week. Generally, most of the recommendations actually tell you 30 minutes, 5 days a week. But as far as type 1 diabetes is concerned, the exercise has to be a bit more brisk. Usual recommendation is almost more than twice as is reported in the general type 2 diabetes exercise studies, and it is equivalent to 7 hours of brisk walking per week or 1 hour of walking per day. But does this really happen with a lot of our diabetic patients? These are all the imputed benefits which have been attributed to exercise in type 1 diabetes. It does lower the blood pressure because of decreased vascular stiffness and reduced insulin dose because increased insulin again has an effect on angiogenesis and atherosclerosis and vessel resistance. It improves muscle and strength and muscle function. We all do know that people with type 1 diabetes have a poor quality bone, and increased exercise because of its load bearing improves bone health, reduce risk of osteoporosis and fractures. Exercise, because of its effects on the GLUT4 receptor, improve insulin sensitivity and exercise insulin glucose uptake. Because muscle is one of those few tissues which can take up glucose independent of insulin, and this again causes reduced requirement for exogenous insulin, lowers risk of diabetic neuropathy, lowers risk of even nephropathy. Many studies have actually shown us that there is a decreased risk of nephropathy. And because your insulin requirement and insulin sensitivity actually improve, insulin requirement decreases, there is a possible role of beta cell preservation. And of course, like in all people, even people who don't have type 1 diabetes, it increases the aerobic capacity. These are all the various benefits which can happen because of exercise. But unfortunately, many of our patients with type 1 diabetes do not derive this benefit from exercise because more than 60% of our patients with type 1 diabetes remain sedentary. And this was actually one study in 2004, which did a randomized control analysis of barriers to physical activity. And this was what they actually found out. The most important reason was a fear of hypoglycemia. The other barriers which were expressed by these people included a work schedule which was interfering with the physical activity, the fact that they already had a loss of their control over diabetes and they were apprehensive about indulging in more physical activity. And most of these patients, because of their sedentary lifestyle, had a low fitness level, which again had a vicious control over. It had a positive feedback over their not going ahead further with a further increased fitness. They were sedentary, they chose to remain sedentary, and this proved to be the biggest barrier to physical activity. And if you actually look at all the various apprehensions which were expressed by these people, the most common of these remained hypoglycemia. Most of these patients were people with type 1 diabetes were actually unaware about the insulin pharmacokinetics. They had a significant number of severe hypoglycemic episodes in the previous year because of overdosing of insulin. And so they were afraid that if they started having exercise, they'd again have more hypoglycemia. The past few weeks, some of them actually had more milder hypoglycemic episodes, and they were afraid that if they actually went ahead with exercise, they'd have more severe hypoglycemic episodes. And they were unaware of the strategies to prevent exercise-induced hypoglycemia. You also had other factors like social support to engage from families and friends, higher HbA1c, which actually contributed more to people having lesser exercise. Males were less likely to exercise. People who were actively smoking were also less likely to exercise, and older people were less likely to exercise. But among all these factors, the single most important reason remained fear of hypoglycemia, as well as your knowledge of mechanisms which could actually prevent this hypoglycemia during exercise. And the reason for this is your typical physiology of what happens during exercise in a normal person as opposed to person in a person without diabetes, as opposed to a person without type 1 diabetes decreases. Generally, in a person who doesn't have diabetes, insulin is produced by the pancreas. So whenever you exercise, your pancreas decreases your insulin levels. It stops producing insulin or reduces your insulin secretion. When blood glucose levels go down, the counter-regulatory hormones, more often than not, glucagon, cortisol, and catecholamines go. They act on the liver to produce more glucose. This acts via both glycogenolysis and gluconeogenesis, and this causes a rise in blood glucose levels. The single most important barrier in people with type 1 diabetes is the fact that pancreas is almost taken out of the picture as far as insulin secretion is concerned. What you're depending on is an exogenous insulin. And more important than not, when you exercise, you cannot reduce the insulin. The first mechanism against hypoglycemia is lost. You cannot reduce your insulin levels. And second, when you exercise, blood flow to peripheral areas increases, especially if you exercise in the limb. Your insulin absorption from the site where the insulin is injected increases. More insulin increases the bloodstream conversely, as opposed to less insulin entering the bloodstream. Then we do have a first stage where there is a rise in glucagon, cortisol, and catecholamines. Some amount of blood glucose is produced by both glycogenolysis and gluconeogenesis. But as you exercise further, because the insulin levels are not going down, the hepatic production of glucose is hampered. Secondarily, we all know that a lot of counter-regulatory responses are lost in people who have long-standing type 1 diabetes. So your glucagon production tails off after a few minutes, and the catecholamine secretion also comes down. As you exercise further and the blood glucose levels fall, you do not have a converse increase in blood glucose levels. This contributes to hypoglycemia because the muscle keeps on taking up glucose. And this is where the difference between normal people without type diabetes and people with type 1 diabetes comes in. And this is what actually contributes to a major increase in exercise-induced hypoglycemia and type 1 diabetes. And for this reason, multiple journals and multiple guidelines have actually given us strategies. Studies have given us strategies to prevent hypoglycemia. One of the commonest we have is what is known as XCARB. Because a significant amount of carbohydrate is lost during exercise or is utilized during exercise, they recommend carbohydrate ingestion before and after exercise by measuring your blood glucose levels. The commonly given dosage is 30 grams of carbohydrate for every 60 minutes of exercise, but this is again variable. It depends on the kind of exercise, whether you're doing an aerobic or a resistance exercise, and also on the weight of the person, the glycemic control of the person. Because if you're well controlled, you tend to ingest more carbohydrate. If you're poorly controlled, your counter-regulatory hormones rise up, and a lot of people with poorly controlled diabetes have a paradoxical rise in blood glucose levels after exercise. Now that CGMS has come in, a lot of these guidelines actually recommend looking at your continuous glucose monitoring. But again, this is not accessible to a lot of people. Many people actually also recommend changing the timing of exercise, doing it in the postprandial state rather than in the preprandial state so that you do not have hypoglycemia. And also looking at your pre-exercise glucose trends. Check your blood glucose levels 1 hour and half an hour before you go ahead with exercise, or half an hour and just before you exercise. And if you have low blood glucose levels less than 140 or 150, take some insulin and then go ahead with your exercise. Take some glucose and go ahead with your exercise. And the most common thing which is recommended, reduction of pre-exercise boluses or cutting down your pre-exercise bolus. Use of insulin pumps where you can do this in a better manner. Or in fact, even doing a post-exercise insulin reduction. That is, if you do your exercise before your dinner or before your breakfast, cut down your pre-breakfast or your pre-dinner insulin level so that you can have less hypoglycemia before lunch or less hypoglycemia early in the morning. But while all these strategies have been recommended, they are not usually very useful. This was a recent guideline which actually looked at the fear of hypoglycemia and whether you have an adaptive response or a disruptive response to hypoglycemia. Whenever you have an adaptive response, you tend to take up both supportive as well as assertive roles, which comprises education about insulin techniques and how hypoglycemia happens in diabetes, looking at well-defined guidelines on exercise-induced hypoglycemia, taking proper use of technology if you can afford it and you have access to it, using newer insulins, ultra short-acting insulins and short-acting insulins, which cause less hypoglycemia, and thereby ensuring that you do not cut down on your physical activity. which is what contributes to your physical and psychological well-being and also a better quality of life. But while this sounds very good and attractive in theory, more often than not, these kind of supportive and assertive roles are not usually available to a lot of our type 1 diabetes patients. And this prompts them to avoid exercise. And this is where we come to the crux of our talk today, the role of glucagon. Generally, if you actually look at anybody with type 1 diabetes and you look at the responses, this is what happens in a lot of people with diabetes. Gradually, as you go further into type 1 diabetes, your duration of type 1 diabetes increases. Your glucagon responses are lost. You can actually see here, hypoglycemia did not elicit a glucagon response. Exercise elicited a very small glucagon response. Insulin withdrawal prior to exercise actually gave you a better glucagon response. Glucose administration actually did not give you a glucagon response. Amino acids and presence of hypoglycemia in addition to an amino acid oral mixture was actually what elicited the best glucagon response in people with long-standing type 1 diabetes. So as you can see, people who exercise, you might have an initial slight rise in glucagon, but later on as you exercise, this glucagon response is lost. And this is what has contributed to our concept that many of our type 1 diabetes with exercise need a glucagon response. This is a brief schematic of how glucagon responses are mediated in type 1 diabetes. There are a lot of factors which actually work on your alpha cell. Somatostatin, which prevents glucagon production. Neuronal stimulations. Catecholamines also have a role in, and catecholamines have a role in increasing the glucagon responses. The GLP-1 and GLP-2, GAP also have a role. And most important among these is the paracrine action of beta cells on alpha cell secretion. As beta cells are gradually lost because of autoimmune actions in people with type 1 diabetes, the paracrine actions of these beta cells are also lost. And this is what actually contributes to a major damping down of alpha cell responses and glucagon secretion in type 1 diabetes. And this is one of the most important factors for hypoglycemia of any form in people with type 1 diabetes, including exercise-induced hypoglycemia. And that is the reason why since 2004, after our understanding of glucagon in diabetes has gone up, many studies have actually recommended using glucagon. The standard dose of glucagon used in hypoglycemia is 1 microgram, 1 mg. But recently, once the newer methods of delivery of glucagon started coming up, we had what is known as a mini dose glucagon as a novel approach to prevent exercise-induced hypoglycemia. One of the first studies was done in 2018, which was a comprehensive study where they looked at using glucose tablets before exercise, giving a mini dose glucagon, and insulin reduction as the three parameters which could be compared. This was a RCT randomized control trial, and people were blinded, and they actually looked at this and compared to the controls. And if you actually look at this, among all of this, insulin reduction caused major rises in blood glucose level post-exercise. Use of glucose tablets actually did not contribute majorly, and you tended to have hypoglycemia. And the most consistent among these obviously remained use of mini dose glucagon. And if you actually look at the glucagon levels, which were checked in between exercise, once you started using a mini glucagon dose, there was a peak of plasma glucagon levels midway between the exercise, which is what is expected in any person with a normal physiology during exercise. And as you stopped exercise, because this was a mini dose, the glucagon level slowly came down so that you did not have a post-exercise hypoglycemia. And among all the groups, this was what was most consistent with plasma insulin levels. The plasma insulin levels remained stable, whereas the glucagon levels came up, which is what is expected in a normal physiology. And if you looked at occurrence of hypoglycemia, the controls had the least amount of hypoglycemia. People who had a reduction in the insulin rate actually had less hypoglycemia. Use of glucose tablets, in spite of giving additional glucose, if the exercise was severe and went on for at least 1 hour, you tended to have more hypoglycemia during the exercise and also during the recovery phase. Whereas among all these parameters as compared to the controls, the best performance was done by mini dose glucagon, where you had the least amount of hypoglycemia during exercise, and post-exercise recovery hypoglycemia was also the lowest. And they extended the study further and looked at the CGM metrics during the late recovery period. The nadir glucose was the lowest for the mini dose glucagon. The mean glucose and the median was actually the best for mini dose glucagon. Number of hypoglycemic events were pretty similar, but the amount of time spent in hypoglycemia was lowest for mini dose glucagon. And the coefficient of variation was also the lowest for mini dose glucagon. And most important, fear of overnight, especially people who exercise late in the evening. The biggest fear we have is of overnight hypoglycemia. And again, among these, the nadir of glucose was among the lowest for mini dose glucagon. The number of hypoglycemic events were lowest. The percentage of time spent in hypoglycemia was again the lowest for mini dose glucagon. Once again, underlining its superiority over reduction in insulin levels as well as use of glucose tablets. And taking this study further, a recent study was done just a few months ago, which again used ready-to-use liquid glucagon. The main problem we have with use of glucagon is the fact that it has to be injected. And it is only recently that we've got liquid glucagon as well as inhaled nasal glucagon. This study used a liquid glucagon and preventing exercise-associated hypoglycemia in adults with type 1 diabetes. This was again a mini dose using 150 micrograms as opposed to 1 mg, which is the commonly used dose. And they actually reported that incidence of hypoglycemia was significantly lower for those who took a mini dose glucagon, either with or without a 50% reduction in insulin basal delivery rate, because all of the patients in the study were on pumps, than those who did not take a mini dose glucagon. Once again, underlining the fact that there is a very good proof of concept for the use of a mini dose glucagon in people just prior to exercise. This is traditionally what we get for glucagon. We've got multiple pre-injectable pens, which give you a calibrated dose. It can be as low as 150 micrograms to 1 mg. These are all the emergency medications. These are essentially used for hypoglycemia in children. They're usually supplied either as a 1 mg or a 3 mg intranasal dose. We've got a recent Baqsimi glucagon powder, which can be used as an intranasal dose, and a recent dasiglucagon, which is a stable liquid glucagon analog, which is not recommended for children below 6, but can be used in children older than 6. And this was what was used in the recent study where they gave them a 150 microgram dose rather than the recommended 0.6 mg, which was 1/4 of the dose. This is the recent nasal glucagon, which has also been approved by FDA. I don't really know whether it is right now available in India, but this is being marketed by Lilly. And this can be a game changer as far as exercise-induced hypoglycemia is concerned. And recently, in the last decade, we've been focusing at insulin and glucagon dual pumps, because the rationale for this is that we've got a coexisting alpha cell dysfunction. And as we have already seen, an impaired alpha glucagon secretion in response to hypoglycemia. And we do have a blunted glucagon rise during exercise, as was shown in the earlier slide. So this was one study which actually looked at a proof of concept of prevention of hypoglycemia during and after exercise. If you used a dual pump which had both glucagon as well as insulin, you spend significantly less time in hypoglycemia with a dual pancreas than a single hormone system, which is what is commonly used, during an extended 60 minutes of continuous as well as interval exercise. And plasma glucagon levels were increased almost 2.5 times by the dual hormone system as opposed to the single hormone system, where we do not have any glucagon secretion. And more important than this, what it actually meant was that you had a reduction in carbohydrate intake, because the commonest thing done by a lot of people after exercise or just prior to exercise is an injection of carbohydrate. This can lead to a weight gain and a prolonged hyperglycemia, because this sets up a habit of defensive snacking in people who have fear of exercise-induced hypoglycemia. And this is where the advantage of a dual hormone pancreas comes in. It could reduce the need for pre-exercise, rescue, or post-exercise carbohydrates. And it also reduces non-nutritive carbohydrate intake, because a lot of our children and adults with type 1 diabetes take this as an excuse to ingest more carbohydrate, which actually has an impact on their long-term glycemic control. And this study actually showed us that more rescue carbohydrate was required in the sensor-augmented pump arm than with the dual hormone system. This was illustrated by the previous slide, where we actually showed that after recovery, you tended to have more hypoglycemia in the exercise arm, whereas you tended to have lesser hypoglycemia in the mini dose glucagon arm. And this was actually corroborated by this study. And most important for a lot of our type 1 diabetes patients who tend to have a significant amount of psychological distress, they tend to have less fear of hypoglycemia. And it improved their exercise-related quality of life, which encouraged more people to get rid of a sedentary lifestyle. To conclude, as all of us know, glucagon response is lost early in type 1 diabetes. There are complex mechanisms why this glucagon response is lost, but almost all of them are coupled to a beta cell loss and the paracrine actions of beta cell. There has been a proof of concept that glucagon administration is of huge benefit in hypoglycemia. And exercise-induced hypoglycemia also we are getting recent proof of concepts. This needs to be administered just before exercise, and the doses are also much lower than what is given in insulin-induced hypoglycemia. Injectable glucagon was a major barrier to adoption of this therapy because of fear of injection and lack of knowledge of parents regarding the proper administration of glucagon. But now that we got a nasal glucagon with a metered administration, this could be a very good mechanism for giving glucagon to children just before exercise so that they don't stack on carbohydrates. The dual pumps have again shown us an impressive proof of concept, but because the dual pumps have still not come into wide use or for commercial use, we have not been able to use this in a wider setting or in larger studies. The big question remains, what is the exact dosing we need, and does dosing need to change based on the intensity of exercise, the weight of the person who is using the glucagon, and the age of the patient, as well as the duration of diabetes? And we do not yet know what are the long-term effects of glucagon, because we do know that even though glucagon causes an initial hyperglycemia, this can be associated with later prolonged hypoglycemia, and whether we need to take some amount of rescue carbohydrates or post-exercise carbohydrates, and the requirement and the risks of long-term or overnight or late onset hypoglycemia with mini dose glucagon is still not fully worked out, because we've got only small proof of concept studies. And this is where the requirement for more studies is needed. But on the surface, at least, this seems to be a very good and a physiological method of cutting down on exercise-induced hypoglycemia. And this is something which definitely warrants a greater amount of study and early incorporation into our exercise regimens with type 1 diabetes, which is sorely needed. With this, I come to the end of the presentation, and